Welcome to the deep dive. Today, we're exploring a region of the body that's, well, absolutely crucial for pretty much everything we do, our head and neck. It's a remarkably intricate area, housing all those functions vital to daily life. Breathing, speaking, eating, seeing, hearing, you name it.
Absolutely.
And so today we're going to take a deep dive into head and neck cancers, or HNCs. We want to understand, where they come from, how they're treated,
Right.
and also the incredible advancements being made to restore not just health, but real quality of life for patients.
Yeah.
And to do that, we've really gone deep into some comprehensive medical texts, giving us, we hope, a truly expert-level perspective for you.
And that expert perspective is, I think, really essential here because anatomically, the head and neck region is it's a marvel of diversity. The normal tissues are incredibly varied. You've got like the tough protective lining inside your nose,
Okay.
then the delicate cells that detect smells, the tiny sweeping hairs, the cilia that clear your sinuses,
Right.
and even the specialized immune-rich tissue in your tonsils, the lymphopithelium.
Wow.
And this incredible variety of cell types and tissues, well, that's precisely why cancers here are so diverse and often complex.
That's a fantastic way to frame it, that complexity. So with such a diverse cellular landscape, our mission today is to try and transform that dense medical information into clear, actionable insights for you, our listener. Sort of a shortcut to being truly well-informed about a group of cancers that impact such core human functions.
Definitely.
All right, let's unpack this. So diving right in, one of the most compelling things we found is how the fundamental causes of these cancers have dramatically shifted over time.
Oh, absolutely.
For a long time, the connection seemed pretty straightforward: tobacco use.
Right. That was the classic association, yes.
But in recent years, we've seen this dramatic rise in viral causes.
That's exactly right. The whole landscape, the epidemiology, has undergone a really significant change. Historically, head and neck cancers, if we exclude salivary and thyroid glands for a moment, were very, very tightly linked to tobacco. But here's the shift. By 2012, human papillomavirus, HPV, was actually causing more oropharyngeal cancers, that's cancers in the back of the throat, tonsils, base of tongue area,
Okay.
than is causing uterine cervical cancers.
Wow.
It had become the most common HPV-associated cancer in the U.S. And just a few years later, by 2015, these HPV-related oropharyngeal cancers accounted for over 40% of all HPV-associated cancers in the States.
40%, that's huge.
It's a massive shift. And we should also mention Epstein-Barr virus, EBV. That's linked to some nasopharyngeal cancers, particularly in certain parts of the world.
Right. So HPV is the big story in the U.S. context for oropharyngeal cancer.
It really is. And this is where it gets critically important from a biological standpoint. HPV positive and HPV negative head and neck squamous cell carcinomas, or HNSCCs. They're now really considered two distinct cancers.
Okay, distinct diseases almost. Why?
Well, the high-risk HPV types, they essentially hijack the cell's machinery. They produce viral proteins. E6 and E7 are the main ones. And these proteins basically switch off the body's natural tumor suppressor genes, like P53 and retinoblastoma. Think of these genes as the brakes on cell growth.
So HPV basically cuts the brake lines.
Exactly. It stops the cells from dying when they should, apoptosis, and pushes them to grow uncontrollably. It's a fundamentally different way for cancer to develop compared to the damage caused by, say, tobacco carcinogens.
That really clarifies it. So they're not just variants, they're fundamentally different pathways.
Precisely.
Which makes you wonder then, even with viruses taking such a prominent role, how do those sort of traditional culprits like smoking and alcohol still factor in? Are they still relevant?
Oh, they're definitely still relevant. Smoking-associated HNCs are still much more common in men, though, interestingly, that male-to-female ratio is actually decreasing a bit.
Why is that?
Primarily due to increased rates of smoking among women over the past decades. Okay.
But here's a curious point about the HPV-associated cancers. They have a much higher male prevalence, about 4 to 1.
Really? Any idea why?
The reasons aren't fully understood yet. It's an area of active research. And it's absolutely crucial to remember the combined effect of alcohol and tobacco. The risk isn't just additive, it's multiplicative. Meaning using both doesn't just double your risk, it increases it many times over. Think of it like 1 + 1 doesn't equal 2, maybe it equals 5 or even more. The combined damage is far greater.
Got it. That's a really important point.
And this sort of leads into another important concept called field cancerization.
Field cancerization, what's that?
Imagine the entire lining of your upper throat and airways, the whole field, has been exposed to the same harmful factors over time, like tobacco smoke.
This means that even after treating one cancer, the surrounding tissue remains damaged or altered. So patients who've had an HNSCC have roughly a 3% to 7% chance each year of developing a second new primary cancer somewhere else in that upper aerodigestive tract, or maybe the esophagus or the lung.
Wow, 3 to 7% per year. That's significant.
It is, and more than half of these second cancers actually appear within the first 2 years of the initial diagnosis.
So it's like the whole region is sort of primed for trouble.
Exactly. The entire field has been pre-damaged, making it more susceptible.
That idea really underscores how widespread the risk can be. So moving on from causes, once a cancer is suspected, what's the journey typically like for a patient? How are these diagnosed and staged?
Well, the symptoms can vary quite a bit, depending on exactly where the tumor is located.
Makes sense.
It might be a persistent sore throat, maybe a noticeable lump in the neck that wasn't there before, hoarseness that just doesn't go away after a few weeks, or perhaps difficulty swallowing, dysphagia.
Okay, so a range of things to look out for.
Definitely. The diagnostic process is pretty thorough. It starts with a detailed patient history, asking about symptoms, risk factors like smoking. Then there's a visual inspection of the mouth, maybe using mirrors. We often use a thin, flexible fiber optic scope passed through the nose to visualize areas you can't easily see, like the voice box or the back of the throat.
Right.
Feeling the neck for any lumps, palpation is also key. And then advanced imaging is crucial, usually CT or MRI scans, often with contrast dye.
What did those scans show?
They help us see the tumor's exact size, where it is, how deep it goes, and really importantly, whether it has spread to nearby lymph nodes in the neck.
Okay, so that gives you the full picture. Then comes staging.
Exactly. We use a universal system called T&M staging. T for tumor size and extent, N for node involvement, and M for metastasis, meaning spread to distant parts of the body.
Standard for most cancers, right?
Yes, but here's what's revolutionary, and a really big step forward from the 8th edition of the HACC staging manual. It now uses completely different T and N classification criteria, and therefore different overall staging groups, for HPV positive versus HPV negative oropharyngeal HNSCCs.
Reflecting that biological difference we talked about.
Precisely. For example, for an HPV positive cancer, stage 5E disease, the most advanced stage, is only assigned if the cancer is spread distantly, so M1 disease.
Okay.
But for an HPV negative cancer, stage 5E can include cancers that haven't spread distantly but are very large, T4, or have extensive lymph node involvement, N2 or N3.
That's a huge difference in definition for the same stage number.
It is, and it really highlights how differently these two types of cancer behave and what predicts their outcome.
That's fascinating how those molecular insights directly change clinical practice like staging. And speaking of clinical practice, our source material really hammered home the importance of a multidisciplinary team.
Oh, absolutely critical.
Can you describe what that truly means for a patient? Who's on this team? How do they work together?
It means a patient's care plan isn't decided by just one doctor in isolation. It's a whole team effort.
Right.
This team often includes head and neck surgeons, radiation oncologists, medical oncologists, but also crucial players like speech pathologists, dietitians, dentists or maxillofacial prosthodontists, social workers, and reconstructive surgeons.
Wow, quite a lineup.
Yeah, they all meet regularly, often in what's called a tumor board, to discuss each individual patient's case. They bring their unique expertise to the table to collectively decide on the best, most tailored treatment plan.
And the source mentioned outcomes are better at high-volume centers.
That's right. The data suggests that outcomes are significantly improved when patients are treated at centers that see a large number of these specific cancers.
Why is that? Just more experience?
Essentially, yes. The teams at these centers have accumulated vast experience with the nuances of diagnosis, treatment planning, managing side effects, complex surgeries, reconstruction, everything. That collective experience makes a real difference.
Makes sense. So what are the general treatment philosophies? How do they decide between surgery, radiation, chemo?
Generally speaking, for early-stage disease, stage 1 or 2, treatment often involves just one modality. That's usually either surgery or radiation therapy.
Okay, single approach.
Right. The choice between them depends on the exact location, potential functional impact, patient factors, and so on. But for later stage disease, stage 3 or 4, it almost always requires a combination approach.
Like surgery followed by radiation, or chemo and radiation together.
Exactly. It could be surgery followed by radiation, sometimes with chemotherapy added, chemoradiation, or definitive chemoradiation as the primary treatment without upfront surgery. For HPV-positive oropharyngeal cancer specifically, concurrent chemotherapy and radiation often provides excellent tumor control, even if it's spread to neck lymph nodes, especially for patients who haven't smoked.
Okay. Now, I've heard this term de-escalation of therapy come up, particularly for those HPV-positive throat cancers. What exactly does that mean? It sounds a bit counterintuitive, like doing less treatment.
Yeah, it does sound a bit strange at first. But it's being explored precisely because these HPV-positive cancers often respond so well to standard, fairly aggressive therapies, leading to very high cure rates.
Yeah.
However, those standard therapies, high-dose radiation chemotherapy, can come with significant short-term and long-term side effects. Things like severe dry mouth, swallowing problems, fibrosis, what we call treatment morbidity.
Right, impacting quality of life.
Exactly. So the goal of de-escalation is to see if we can maintain those excellent cure rates while reducing the intensity of the treatment, and therefore reducing the side effects and long-term harm.
How would they do that? Less chemo, less radiation.
It could involve several strategies. Maybe limiting the chemotherapy, perhaps using a less toxic drug, or decreasing the radiation dose or shrinking the radiation fields, or even exploring surgery, like transoral robotic surgery, TITORs, as the only treatment for selected early-stage cases, avoiding radiation altogether.
Is it working? Is it safe to do less?
It's a very careful balancing act. Some studies have shown promise, but others, like a major trial called RTOG 1016, found that substituting one chemotherapy drug for a targeted therapy alongside radiation actually led to worse outcomes for HPV-positive patients.
Ah, okay, so it's not straightforward.
Not at all. It shows that simply doing less isn't always better, and we need really strong evidence from clinical trials before changing standard practice. Dis-escalation is still largely investigational.
Got it. Now, you mentioned something earlier that seemed paradoxical, about smoking history being predictive for HPV cancers.
Ah, yes. It's one of those surprising clinical observations. Even though tobacco smoking doesn't cause HPV-related oropharyngeal cancer,
Right.
a patient's history of tobacco smoking is currently the single most significant clinical marker we use to predict how well they'll respond to treatment and their overall survival chances in HPV-associated disease.
Wait, so smokers with HPV cancer do worse, even though smoking didn't cause that specific cancer?
Correct. Patients with a heavier smoking history tend to have poorer outcomes compared to non-smokers with the same stage of HPV-positive cancer.
Why? Any theories?
The exact biological reasons are still being teased out. It might be related to other genetic damage caused by smoking, or perhaps effects on the immune system, or maybe just overall poor tissue health, making it harder to tolerate treatment or fight the cancer effectively. It's complex.
Huh. That's really fascinating. Are there other markers emerging?
Yes, and this is exciting. Research has identified defects in two specific genes, TRAF3 and CYLD, which are found in about 30% of HPV-positive HNSCCs.
Okay.
And these defects seem to be associated with improved survival, so they're emerging as promising new predictive biomarkers. Identifying these could potentially help select patients who might be good candidates for de-escalation therapy in the future.
Ah, so that could be a way to personalize de-escalation based on specific tumor genetics?
Potentially, yes. That's the hope.
Okay, shifting gears slightly. We hear so much about immunotherapy across many cancer types. How is it impacting head and neck cancer treatment?
Immunotherapy has definitely made an impact, particularly for patients whose cancer has recurred after initial treatment or has spread distantly, becoming metastatic.
How does it work in this context?
The main approach uses drugs called checkpoint inhibitors, specifically targeting the PD-1/PD-L1 pathway. Essentially, some cancer cells use this pathway to put the brakes on the immune system, telling T cells not to attack.
Okay.
These drugs block that signal, releasing the brakes and allowing the patient's own immune system to better recognize and fight the cancer cells.
And the results?
They've been approved for recurrent and metastatic HNSCC. Initial response rates were maybe around 20% or so, but for the patients who do respond, some of those responses can be remarkably durable, lasting for years, which was almost unheard of before.
So, life-changing for some, but not everyone responds.
Exactly. While it's a very promising and important new tool, that overall response rate in the recurrent metastatic setting, currently around 13% to 20%, clearly tells us we need better ways to predict which patients are most likely to benefit. Identifying better biomarkers for immunotherapy response is a major focus of research.
Right, more personalization needed there too. Okay, as we've touched on, the head and neck region is just incredibly diverse anatomically. And that diversity surely plays out in the cancers themselves. Each specific site must present unique challenges and maybe require different approaches.
Absolutely. The location makes a huge difference. Let's maybe walk through a few key sites.
Great idea. Where should we start?
Let's start with the oral cavity of the mouth, lips, tongue, floor of mouth, gums, palate.
Okay.
This is actually the most common site for head and neck cancers overall. Over 90% are squamous cell carcinomas.
And what's the key takeaway for listeners here?
I think the most important thing is prompt evaluation for any persistent lesion in the mouth. Anything that doesn't heal in, say, 2 or 3 weeks. Especially look out for red patches, what we call erythroplakia.
Red patches are worse than white ones.
Generally, yes. While white patches, leukoplakia, can sometimes harbor precancer or cancer, erythroplakia has a significantly higher chance of being malignant or premalignant. So persistent red patches really need urgent attention.
Good to know. And treatment for oral cancer.
Surgery is generally the preferred initial treatment approach for most oral cavity cancers.
Okay. What about the neck itself? You mentioned lymph nodes earlier.
Right. The neck isn't usually where a primary tumor starts, unless it's skin cancer or maybe thyroid. But its lymph nodes, the cervical lymph nodes, are absolutely critical because they're often the first place cancers from the mouth, throat, larynx, etc. spread to.
So managing the neck nodes is key.
Essential. When we talk about surgically removing these nodes, historically there was the radical neck dissection, or R&D. This was a big operation, removing lymph nodes from levels I to V, but also structures like the main neck vein, jugular, a major muscle, sternocleidomastoid, and an important nerve, spinal accessory nerve, that helps move the shoulder.
Sounds quite invasive.
It was, and it often left significant functional deficits, like shoulder droop and chronic pain. The big advance has been the development of modified radical neck dissections, or MRNDs, and selective neck dissections.
How are they different?
They aim to remove the necessary lymph nodes at risk, but preserve one or more of those non-lymphatic structures, the nerve, muscle, or vein, whenever possible, without compromising cancer control.
And they're as effective.
Yes, for many patients, these modified or selective dissections provide equally effective cancer control, but with much better functional outcomes and less long-term morbidity. We're also seeing advancements like sentinel lymph node biopsy being used more for early-stage oral cancers.
What's that? Like in breast cancer?
It's exactly the same principle. Injecting a tracer near the primary tumor to identify the first 1 or 2 lymph nodes it drains to, sentinels. If those are clear, you might be able to avoid a larger neck dissection. It's less invasive.
Interesting. Okay, moving down a bit, what about the larynx, the voice box?
The larynx. Such a critical organ. It has 3 vital functions: breathing, protecting the airway during swallowing so food doesn't go down the wrong way, and of course producing voice, phonation.
So cancer there is particularly impactful.
Extremely. The key symptom to watch for is dysphonia, or hoarseness, a change in voice quality. Any hoarseness lasting more than, say, 4 to 6 weeks really should be evaluated by specialists, usually with that fiber optic scope I mentioned.
And treatment. I imagine preserving function is a huge goal.
Absolutely. There's often a real tension in treatment decisions for laryngeal cancer between maximizing the chance of cure and preserving as much laryngeal function, voice, swallowing, breathing as possible.
How do you balance that?
It depends heavily on the stage and exact location of the tumor. Sometimes early cancers can be treated effectively with radiation alone, or with minimally invasive laser surgery through the mouth, preserving the larynx. More advanced cancers might require surgery, potentially a partial or total laryngectomy, often combined with radiation or chemoradiation.
Total laryngectomy. That means removing the whole voice box.
Yes, it's a life-altering surgery, but sometimes necessary for cure. When the larynx is removed, the windpipe, the trachea, is brought directly out to the skin of the neck, creating a permanent breathing opening called a stoma.
How do people speak after that?
There are actually several remarkable speech rehabilitation options. One is using an electrolarynx, a handheld device that creates vibrations when held against the neck, which the patient shapes into words with their mouth.
Okay.
Another is esophageal speech, which takes a lot of practice, but involves learning to swallow air into the esophagus and then expel it back up in a controlled way to vibrate the throat tissues and create sound. And probably the most common and often most effective method today is a tracheoesophageal puncture, or TTEP. A small surgical passage is made between the trachea and the esophagus, and a little one-way valve, a voice prosthesis, is placed in it.
How does that work?
When the patient covers their stoma and exhales, air is shunted from the lungs through the prosthesis into the esophagus, vibrating the tissue to create a sound source for speech that's often quite natural sounding.
That's incredible rehabilitation.
It really is. And just a crucial clinical point.
Yeah.
Patients who have had a total laryngectomy have their airway disconnected from their mouth and nose. They cannot be intubated through the mouth if they need respiratory support. Airway access is only through the neck stoma.
That's vital for emergency responders to know.
Absolutely vital.
Okay, what about salivary glands? We have several, right?
Yes, 3 pairs of major glands. The parotid, which is the largest, located in your cheek in front of your ear. The submandibular, under your jaw. And the sublingual, under your tongue. Plus, there are hundreds, maybe up to 1,000, tiny minor salivary glands scattered throughout the lining of your mouth, throat, nose, and sinuses.
And they can all develop tumors.
They can. Salivary gland tumors are quite diverse histologically, but there's a fascinating pattern regarding malignancy.
Oh.
Generally speaking, the larger the salivary gland, the less likely a tumor within it is to be malignant.
Really? That seems backwards.
It does, but it holds true. So tumors in the parotid gland, the biggest one, are malignant only about 25% of the time. Most are benign.
Okay.
In the submandibular gland, it's closer to 50% malignant. And in the tiny sublingual or minor salivary glands, tumors are malignant around 75% of the time, or even more.
That's a really interesting inverse relationship. Any warning signs for salivary malignancy?
A key red flag, especially with a lump in the carotid gland region, is any sign of facial nerve weakness or paralysis on that side. The facial nerve runs right through the parotid gland, so if a tumor affects the nerve, it's highly suspicious for malignancy. Pain is another warning sign.
Got it. What about the nasal cavity and paranasal sinuses? Behind the nose and the cheekbones.
Yes, those areas. The biggest challenge here, unfortunately, is often late diagnosis.
Why is that?
Because the early symptoms, things like persistent nasal congestion, maybe some discharge, facial pressure, or headache, are so common and easily mistaken for allergies, chronic sinusitis, or just a cold.
So people might ignore them for a long time.
Exactly. By the time more alarming symptoms appear, like facial swelling, vision changes, or numbness, the cancer may already be quite advanced.
Are there any specific types of tumors here?
Squamous cell carcinoma is common, but there are others like adenocarcinoma and less common types. There's also an interesting benign tumor called a Schneiderian papilloma. One type, the inverted papilloma, while benign, can be locally destructive and has about a 10–15% chance of having or developing a squamous cell carcinoma within it.
So even benign needs careful watching.
Definitely. And surgery in this area is incredibly complex because you're right next door to so many critical structures. The eye socket, orbit, the brain, the base of the skull, major arteries like the carotids. Resections often require very specialized skull-based surgery techniques.
Requires a highly skilled team again.
Absolutely. Often involving neurosurgeons as well as head and neck surgeons.
Okay, one more site, the nasopharynx. You mentioned EBV connection earlier.
Yes, the nasopharynx. That's the area at the very top of the throat, behind the nasal cavity. Anatomically, it's quite distinct. Cancers here, primarily nasopharyngeal carcinoma, NPC, have a very striking geographic distribution.
Where are they most common?
There's a very high incidence in certain endemic areas, particularly southern China, Southeast Asia, North Africa, and also among Inuit populations.
And that's linked to EBV.
Yes, there's a very strong correlation between EBV infection and endemic MTC. The virus is found in nearly all tumor cells in those regions. However, HPV is also being found in some NPCs, maybe up to 20%, particularly in non-endemic areas, and there seems to be a trend toward improved survival in those HPV-positive cases, similar to oropharyngeal cancer.
Interesting. So we've covered the causes, diagnosis, treatment approaches, the site-specific challenges. What does this all mean for someone actually going through treatment? Beyond just removing the cancer, there's this whole aspect of reconstruction.
Yes, and reconstruction is absolutely crucial. It's not just cosmetic. It's fundamental to restoring a patient's life and function after potentially disfiguring or debilitating cancer surgery.
So what are the main goals when surgeons plan reconstruction?
The source material highlights 3 prioritized goals, often thought of in this order. First, and most importantly, is separation. Meaning safely separating and protecting sterile compartments like the inside of the skull, intradural space, the chest cavity, mediastinal space, or the deep spaces of the neck from contamination from the mouth or throat, which are obviously not sterile. This prevents life-threatening infections like meningitis or mediastinitis.
Okay, safety first. What's next?
Second priority is maximizing function. This is about restoring as much as possible those critical abilities we talked about. Breathing, speech, swallowing, vision, hearing. Function is paramount to quality of life.
Makes sense. And the third goal?
The third goal is optimizing form, or cosmesis. Restoring appearance is incredibly important for a patient's self-esteem, social interaction, and overall well-being. But usually, it's prioritized after ensuring safety and maximizing function.
That makes perfect sense. Now, you mentioned a concept in the source called the reconstructive elevator, not a ladder.
Right. The reconstructive elevator is a great concept. The traditional reconstructive ladder implied you start with the simplest technique and only move up to more complex ones if needed. The elevator idea emphasizes that sometimes the best option for a particular defect, the one that gives the best functional outcome, or maybe even the best long-term cancer outcome, might be a more complex technique right from the start. You don't necessarily have to climb the ladder. You might just take the elevator straight to the best floor, so to speak.
So sometimes a more advanced technique like free tissue transfer is actually the preferred first choice.
Exactly. Even for what might seem like a simpler defect, if a free flap offers superior function, like better tongue mobility for speech and swallowing after a tongue resection, then it might be the best initial choice.
Can you briefly explain what free tissue transfer or a free flap is?
Sure. A free flap involves taking a section of tissue, which could be skin, muscle, bone, or a combination from a distant part of the body, like the forearm, thigh, back, or leg. Crucially, you take it along with its own dedicated artery and vein, its blood supply. Then you transfer this composite tissue block to the defect in the head and neck. Using microsurgical techniques under a microscope, you meticulously reconnect the flap's tiny artery and vein to recipient blood vessels in the neck.
So you're essentially transplanting tissue with its own plumbing.
That's a great way to put it. You reestablish blood flow, allowing the tissue to live in its new location. High-volume centers have very high success rates for these procedures, often over 95%.
That's amazing technology. Are there other tech advances in reconstruction?
Yes, another really exciting area is virtual surgical planning, or VSP, especially for reconstructing the jawbone, the maxilla or mandible.
How does that work?
Using the patient's CT scan data, surgeons can virtually plan the entire operation on a computer in 3D. They can precisely plan where to cut the bone to be harvested, say from the fibula in the leg, and exactly how to shape and position those bone segments to perfectly reconstruct the jaw, ensuring the teeth will align correctly, the occlusion, and achieving good facial projection.
Wow.
Then, based on this virtual plan, custom 3D printed surgical guides or jigs are made. During the actual surgery, these guides snap onto the bones, telling the surgeon exactly where to cut and where to place the bone segments. It takes a lot of the guesswork out and leads to much more precise and predictable results.
That's truly incredible. It really underscores how reconstruction isn't just an add-on, but a deeply integrated part of the whole treatment plan, reinforcing that multidisciplinary approach we keep coming back to.
Absolutely. The reconstructive plan is often considered right from the initial surgical planning stage.
So to kind of wrap things up for you, our listener, what we've really unpacked today is, I think, the incredibly dynamic and complex nature of head and neck cancers.
Very dynamic.
We've seen the critical and growing role of viruses like HPV fundamentally changing the landscape of these diseases.
Right, creating almost distinct entities.
Exactly, and the personalized approach that's needed for treatment, considering every nuance of the cancer, its location, its stage, its molecular profile like HPV status.
And the patient's own factors like smoking history.
Right. And finally, the really incredible advancements in both the surgical techniques to remove the cancer and the reconstructive methods that aim to restore not just health, but truly a patient's quality of life, their function, their appearance.
And I think understanding these nuances really helps you appreciate the profound impact these diseases can have, but also the dedication and ongoing efforts in research. For instance, that search for new biomarkers like the TRAF3 or CYLD gene defects we discussed.
Yeah.
That holds such promise for developing even more tailored therapies, maybe safer de-escalation strategies in the future, ultimately improving both cure rates and the patient experience by minimizing those tough side effects.
Absolutely. It's a field with constant evolution. So maybe a final thought for you to mull over. Considering the remarkable adaptability of the human body, which we see in things like speech rehab after laryngectomy, and the continuous evolution of medical science we've discussed today, what further breakthroughs in personalized medicine do you think will emerge next to really transform the lives of patients facing these complex cancers?
That's a great question to ponder.
Thank you so much for joining us on this deep dive into head and neck cancers. We hope you found it informative and that you'll continue your learning journey with us.